Professor McFarlane is Professor of Psychology and the head of the University of Adelaide Centre for Traumatic Stress Studies. He's an international expert in the field of the impact of trauma on veterans, disaster survivors and civilian accidents. Sandy has had the role of the Senior Advisor in Psychology to the Australian Defence Force and the Department of Veterans Affairs. He holds the rank of Group Captain in the RAF Specialist Reserve, and he's acted as an advisor to many groups in post-disaster situations, including the Kuwaiti government, the United Nations, and has lectured and run workshops in Europe, the United States of America, Asia and South Africa. His research has focused on the epidemiology and longitudinal course of post-traumatic stress disorder, as well as the neuroimaging of the cognitive deficits in this disorder. He has a particular interest in the impact of childhood trauma and its impact on adult adjustment. He also has had significant experience in the provision of care to emergency service personnel. He has published over 300 articles and chapters in various referenced journals and has co-authored and edited 3 books. In 2011, he received the Officer of the Order of Australia in the Australia Day Honours List. That award recognised his outstanding contribution to medical research in the field of psychiatry, particularly post-traumatic stress disorders, to veterans' mental health management, and as an author. Ladies and gentlemen, Professor McFarlane will talk to us on the prevalence of PTSD and directions for research. Please make welcome Professor McFarlane.
Just to save my psychology colleagues the embarrassment, I am a psychiatrist. So I've been asked to talk about God and the nature of the universe in the next 25-30 minutes. So really what I'm going to try and do is give a bit of an overview rather than just to bore you with numbers. But before I start, I would like to particularly acknowledge Tony Dell in organising this meeting, and I think the sort of advocacy that he's endeavouring to put forward is an incredibly important issue. And science doesn't happen in a vacuum. It happens because it's about real people. And equally, having Sir Angus as the patron of this group is a real acknowledgement of its significance to the broader Australian community. It is the centenary of Anzac, so I'd like to begin by just making a few reflections about where we've come from. In 1938, and this is an extraordinary figure, the cost of pensions to World War I veterans was 1/5 of the total expenditure of the Commonwealth. Can you imagine that today? An extraordinary amount of money. And I think we need to reflect on that because it did actually drive a lot of the attitudes which I think occurred at that time, because particularly in the aftermath of the Great Depression, there was a considerable concern about the way that veterans were receiving monies from the Commonwealth. And it led to many, I think, prejudicial judgments about the nature of the veterans' ill health. Alistair Thompson, who's a Professor of History at Monash University, has written a very interesting volume. But he highlighted how the repat files are crowded with moral judgments about family traits and mental weakness. So in other words, men's difficulties were not being attributed to the exposures they'd had in the war, but rather to pre-existing complaints and vulnerability. In fact, when you read that literature, it's remarkable how little emphasis there was on how the exposures they'd had led to their ill health. And particularly in the aftermath of the war, the dialogue was very much around, this was about compensation seeking, exaggerated disability, and even during the war, many of these people were considered as being malingerers or seeking to shirk their responsibility. And I think to just give this some context, this view or prejudice against the sufferers of post-traumatic stress disorder is alive and well, and I think we're hearing about it in the current Royal Commission in child abuse. Just last week, there was a young man who had been sexually abused at Geelong Grammar. Because he spoke to several of his friends at school about it, he was expelled from the school whilst the paedophile master continued to be employed. And I think one of the reasons why that happened at the time is because it's when the law and the limitation of liability becomes an issue. An appropriate and real approach to solving the problem is put to one side. And unfortunately, this is a field that has been very influenced by that issue. And I think this is where epidemiology comes in, because the Vietnam veterans, when they came back from that war, and particularly those who were suffering mental afflictions, were often diagnosed with things like inadequate personality disorder. And in the US, the system didn't turn to them with open arms. The reason why this happened was because of Senator Cranston and Senator Inouye, who basically took on the Vietnam Veterans the Veterans Administration in the US. And one of the things that they did was to mandate the Vietnam Veterans Readjustment Study, and this could not be performed by anybody who had any association with the Veterans or Defence System in the US. And this was a seminal study that was first published in 1990 and then reanalysed in 2006, and basically showed that in the 10 to 12 years following the Vietnam War, 9% of the returned servicemen were suffering from post-traumatic stress disorder. And the important thing about this reanalysis was that that study had been criticised because there were claims of falsification of people's military service. And when that was very carefully looked at, that wasn't found to be the case. So this was a very real problem that the bureaucracy of its own initiative hadn't turned to solve. It depended upon other veterans to advocate for those in need. Importantly, several weeks ago, the further follow-up, 25-year follow-up of that cohort has occurred. And it's shown that in the entire cohort, the rates of PTSD currently at 10.8% with a lifetime rate of 26.2%. The important issue, though, was in the combat veterans who had a higher rate, about 14%. And this was something which I think the system back in the First and the Second World War didn't understand, was that the rates of disorder are still increasing, despite this being 40 years after the end of that conflict. And this delayed onset and delayed emergence of post-traumatic stress disorder, in fact Tony highlighted that he was one of those people, is something that we have to anticipate. And so currently there's still over 250,000 Vietnam veterans who are suffering from PTSD. In Australia, there's been a similar study of our Vietnam veterans, and we found that there were higher rates of PTSD in Australian veterans, and the reason for that was because we had a greater percentage in combat-related roles. I mean, of course, the important issue is that PTSD is not the only condition that arises from military service or services in the emergency services. Now, the issue is this a problem? Is this something we need to be concerned about? And I think one of the reasons why a meeting like this is so important is because I think the dialogue around mental health has changed greatly in recent years, and Beyond Blue and the leadership of people like Jeff Kennett, I think has been instrumental in the public debate. Equally, the Commonwealth Department of Health has now run 2 national studies of mental health epidemiology. The last one was done in 2007. But one of the pieces of information that isn't often emphasised in that study is that the most common disorder isn't depression, it's post-traumatic stress disorder. Now, I think this is a critical issue, is why don't we have a national strategy or a national approach? And one of the reasons is because the populations who are affected exist within multiple different jurisdictions, even within state governments and departments, whether they be the victims of child abuse, domestic violence, emergency service workers, motor accident victims, or members of the Defence Force. One important group, and this is a study that I've done with my colleagues who are going to be speaking next, and it's taken from 4 major teaching hospitals around Australia, looking at people admitted after accidental injury. There are 2 points that I'd like to emphasise about this study. This is following the 12 months and now being followed up for 6 years. The first thing is that post-traumatic stress disorder isn't the most common disorder onsets after an accident. It's actually depression. 22% of this population had a new disorder after the accident. But the critical point is that only 33% of them are actually in treatment. Now you've got to remember, these people with physical injuries who are in contact with our health system, and it highlights the lack of identification that even exists in the current environment and the difficulties of diagnosis. Another important observation that came out of this study, that not everybody who's involved in an accident in Australia can be the recipient of compensation. The rates of disorder weren't any different between those receiving compensation and those not receiving compensation. So compensation is not the issue. It's that these people have been psychologically impacted upon by their experience. Now, I think the Australian Defence Force is an example for other employers in Australia. I think under Sir Angus's leadership and the openness of Joint Health Command to get involved in this, we did a study of the entire Defence Force in 2010, using a methodology which was almost identical to that used in the national study that was done in 2007. And this allowed us to select a subgroup of that study and to compare them with the Defence Force. And the interesting finding here was that the rates in the Australian Defence Force were not statistically different from the Australian community. The rates of depression were higher, and interestingly the rates of alcohol abuse, despite people's anticipation, were slightly lower. And if you're wondering about that last figure, John Bannon, who used to be the Premier of South Australia for a time, was the Master of St Mark's College, University College in Adelaide, and he said he was astounded by the amount that young people could drink and still excel in their examinations. So I don't think the Defence Force has a monopoly on the issue of how young people behave. Just to look further within that data, although there were no high rates of anxiety disorders in the Defence Force, the rates of post-traumatic stress disorder were in fact greater, where 8.3% of the Defence Force had PTSD, in contrast to the equivalent population in the community of 5.2, because I was looking predominantly at younger males. Now, one finding that really surprised people in this study was that the rates of PTSD weren't higher in the deployed individuals, the 66% of individuals in the Defence Force are deployed. Now, this, I think, highlights one of the difficulties about epidemiology. And the issue was, when we looked at this more closely, that deployment is not a random phenomenon in the Defence Force. The people who deployed looked very different in many ways. They were older, were more likely to be NCOs and commissioned officers. They were more likely to be in stable relationships. So the background, the risk factors within these populations are very different. And one of the things we always have to think about when we're doing epidemiology is the issue about healthy warrior effects. People may not be aware that at the time of the Vietnam War, when conscription existed, 50% of people who were potentially conscripted were rejected as being medically unfit. And even today, the mortality of Vietnam veterans is slightly lower than the general community. But the reason is because they pre-selected a highly fit and capable workforce. So simply making comparisons with the community is slightly problematic, because I think we've got to be very careful about how we interpret those findings, because the lack of differences with the community doesn't mean the absence is a problem. Because the issue is these are a group of people who should have lower rates probably, and so the rates tell us something about the background risks that they've been exposed to. I mean, one of the other things that we need to think about in epidemiology, the proactive health system in the Department of Defence, means that in fact potentially these people should have been identified and treated more effectively than in the broader community. So I think one of the things we mustn't do in epidemiology is make too many comparisons with supposed control groups, because the differences in those populations that have nothing to do with the exposure might explain the lack of differences. Now, if I can just move to the emergency services, because in fact there is a lack of good information about the emergency services in Australia. Whilst there are claims made about the rates in the Australian emergency service environment, we're currently doing a study of the entire Metropolitan Fire Service in Adelaide, using the same methodology we use in the Defence Force. And that's the sort of methodology that you've got to use. You can't simply look at things like your compensation statistics, because the declared cases are likely to be very much less than the actual cases that exist. A valuable insight into the broad body of literature was published in a meta-analysis in 2012 that's basically bringing together a whole range of epidemiological studies around the world, which suggested that about 10% of individuals in emergency services around the world have PTSD. Ambulance officers, interestingly, were the group who had highest rates. And the important issue that was identified, and this is what you'd presume, is that the longer their service, the greater the probability they were going to have PTSD, because this is about cumulative exposure. Now, I think that the emergency services, if we're going to do better in this space, present a real problem. Firstly, in South Australia, the ambulance service, police service, the police force and the fire service sit in different ministries. So there's no integration of the way that they manage or deal with the issue of mental health. Equally, because we have this fragmented system brought on us by colonial history and federation, there's very little central coordination or policy development at a national level. And unfortunately, it remains the case that in many of these organisations, the predominant driver of the health system is about compensation management rather than around effective early intervention and treatment. Because you can see the problem is, if you have early intervention and early treatment, you increase your case rates, which looks bad on your compensation figures. And the other problem, I think, for the emergency service, the veterans community is a very important advocate for people who've served in the Defence Force. There's no similar advocacy movement for the people who've served in the emergency services. So the importance of epidemiology is that it defines the size of the populations that we need to address. It's critical for planning. These are the sort of documents that convince politicians. The study we did of the Defence Force has played a very important role in, I think, addressing a number of issues about the delivery of mental health care, particularly around the issues of unmet need and how service delivery needs to be modified. The other thing is these are the sorts of bodies of data that allow us to begin to look at questions of causation and answer some of the controversies around compensation. And I think probably getting people to realise that PTSD just isn't an issue of compensation has been one of the huge shifts that's happened in the last 30 years that we underestimate about how this development of the capacity given to us by computing science has actually validated, I think, post-traumatic stress disorder in many domains. And currently, we're involved in, Dr. Miranda Van Hoof is the principal investigator in this in my centre, with a group of collaborators from around the country, where we're doing the Transition and Wellbeing Research Program, which is a critical project where we're trying to actually look at those people who leave Defence, because it makes sense that the people who leave the Defence Force are not a random sample. They're likely to be the people who've been struggling. And this program is also going to go back and look at people who we first studied back in Defence, as well as families, and a study we did of our neo-veterans. And this requires a great deal of commitment and organisation. And any of you who are ex-serving personnel or currently serving personnel, if you're asked to participate, I would strongly request that you assist, because it's only when we get a proper window of what's going on that we really can better improve service delivery and address the issues of concern to currently serving in the veterans community. Now, I was also asked to make some comments about future directions of research, and this is, again, you're going to run a 5-day meeting on this, so just a few sort of reflections and thoughts. So going back to the First World War, I mean, the great debate in the First World War was the issue about whether this was a condition that was caused by the psychological stress of war, or whether it was caused by the explosion and the concussive force of shells. And there was an instrumental report by the War Office in 1922 in England that really looked at the evidence and came to the conclusion that really it wasn't about blast exposure. Rather, this was deemed a functional or psychogenic disorder. Now, I think in many ways this put us back in time, because it was seen to be an issue about people's motivation, about their moral fibre, about conflicts that may have come from early developmental issues, rather than looking at the role of environmental exposure. And it really discouraged a neurobiological basis. Now, the other thing that I think we need to really keep in mind when we think about our future research agenda, and David Forbes will make a number more comments about this, is that I think we need to make an honest appraisal of where we are in the treatment space, and Rakesh Jetli made some valuable comments about this before, because we have come a long way, but I think there is still significant room for improvement. And a study, a meta-analysis that was published in the main medical journal of the American Medical Association, again just published a couple of weeks ago, highlighted whilst people with psychological therapies in the military populations have significant improvements, at the end of treatment, still 66% of them retain the diagnosis of PTSD. And that tells us about the space that we have to capture. We still have a long way to go. I think developing further evidence-based treatments, and Rakesh Jetli made some comments about this, is a critical challenge for us, and David will talk some more about this. So if we were going to sort of try and summarise what the future directions are, it is around this issue around treatment, but I think particularly it's about looking at the underlying neurobiological mechanisms of this disorder, in particular biomarkers. And one of the challenges here is to do this sort of research is very expensive, and it requires a coalition of interest between the people who this is relevant to. I mean, as a researcher, I can't just deem that we want to do a particular study. It requires an engagement and a shared aspiration with the participants. And one of the things that we've got to do is to really look at the progressive emergence of these disorders over time, and the difference of the biology of the person with an acute illness from somebody with a chronic disorder. And this demands a great deal of coordination and long-term planning. You know, for example, we have got still ongoing conflicts in the Middle East, and you know, I think we need to be discussing, well, what sort of research program are we going to be putting in place for these currently exposed personnel? We've done this for the cohort who were exposed up until 2011, but the problem hasn't gone away. And this does require a national debate and a debate in many domains. And the other issue that I think we really need to contemplate is that having a capacity to do research doesn't happen in a vacuum. And particularly with the downsizing of DVA, an organisation that's gone from roughly 16,000 personnel in 1990 down to just over 1,000 people, we shouldn't assume that we're going to sustain and maintain our capacity for this work. I mean, people don't get taught well about post-traumatic stress disorder in clinical psychology master's programs or in the psychiatry training programs. Somebody has to teach people in this space, and equally, you have to sustain the research capability. It's a bit like building submarines. You can't build a submarine and then stop for 10 years and then expect to have that capacity sitting in the community. You need to have a continuous program of work to maintain capacity. Now, just going back to that issue about World War I and blast exposure. Now, this is a very simple finding, but it's something that's worth contemplating. There was a study published, which was again one of these meta-analyses that brings together a whole range of work that's been done. It was published in 2010, that looked at trying to estimate the brain volume. It's just looking at structural MRI and CT. The actual current volume of the brain of people with PTSD as against what the maximal size of their brain was. And the way you do that is looking at the difference between the inside of the cranial vault and the current size of the brain. And basically what this showed is that the total brain volume is significantly smaller in adults with PTSD compared with trauma-exposed controls. Now, interestingly, the total intracranial space didn't differ in the population with PTSD. So it suggested that as a consequence of this disorder, there had been a significant loss of neural tissue. And you see, that doesn't come out of bad motivation or bad thoughts. Something else must be going on. And a recent study that really takes that a little further was looking at a group of police officers. And essentially what they were trying to do was to relate changes in brain volume in particular parts of the brain with trauma exposure. And this wasn't police officers just with post-traumatic stress disorder. It was people who had a range of symptomatology, from no symptoms to subsyndromal symptoms to PTSD. And what it first of all showed is exactly what we would predict. The greater the probability of PTSD occurs, the greater the number of trauma exposure you've had. But increasingly, the more exposure you've had, the increased indices there were of brain atrophy. And that was particularly related to the re-experiencing phenomenon. So again, you can see this is a problem that is, this is very simple evidence that emphasises the neurobiological basis of this disorder. And what are we going to do about it? This is why we need to think about, what sort of treatments might need to address this. Just talking about it is not going to make your brain swell. And this is a slide that's taken from the study we did at the Defence Force. Down the left-hand side is the probability of having symptoms of post-traumatic stress disorder, and along the bottom is the number of trauma exposures. And you can see that the greater the number of trauma exposures you have, the greater the probability that you've recruited some symptoms of post-traumatic stress disorder. And the issue for us, you see, is to understand what are the markers, if we can begin to look at what are the markers within the individual of this increasing exposure, and whether there are steps that can be taken to reverse this prior to somebody going on to develop a full-blown condition. Now, I haven't got time, and Rakesh covered this to a significant degree. There are a range of biological systems. One of the really fascinating questions these days is, for example, around the way that genes can be switched on and off. Now, if we're going to get involved in this space, we have to do genetic research. And there's been some reluctance to take this on in the defence community. Our allies are doing this, we've got to get involved. I think this is an area where there's a great opportunity for international collaboration, and we need to be part of that research community. So post-traumatic stress disorder, I think, we now know, is not just a disorder. It's to do with thoughts and unresolved psychological conflicts. It's a disorder about brain pathology. And that's not to say that thinking about the psychological aspects of this and the experimental nature of it is not absolutely critical to understanding people and treatment, but we mustn't get too focused on that approach. I think the other reason why this is absolutely critical for us to get into is because many of the mechanisms that underpin post-traumatic stress disorder are not isolated to this condition alone. They're shared mechanisms that influence disorders like depression, but equally physical diseases that we know have a significantly increased relationship with PTSD. I didn't focus on the previous slide. One fact that people sort of forgot about with the First World War veterans, they had a 13% greater mortality if they'd fought on the Western Front. You know, it's been shown with police officers they have a higher rate of mortality than their police force, not just from suicide, it's from ill health. And it's because post-traumatic stress disorder is a marker of a more general biological dysregulation in systems like the immune function that we need to understand something about if we're going to really, I think, have further improvements in the treatment and care of people. So just to conclude, you know, I think we do have a great need to think about how we're going to sustain and develop expertise at a national level, because there is a significant degree of fragmentation of our efforts around post-traumatic stress disorder in the Australian community. I think the veterans community and the Defence Force you know, provide leadership because this is a collective national concern. But I think there are many other groups who suffer silently in our community without the same sort of advocacy. And I think it's very interesting that the Australian of the Year is Rosie Baddick, but we don't talking about the issues of treatment and assistance for domestic violence victims. And you know, we're focusing on prevention. Now, that's a critical issue, but we mustn't forget the burden that is within the community around domestic violence. I think we need to think about the shared benefits for the improvements that we've achieved to a degree in the defence space and try and make sure those transfer to the emergency service space. But again, the mechanisms of that happening with our current system of government, I think, are highly problematical. We have this need for the development of innovative neurobiological treatments and service delivery models, but the critical issue is they need to be centred around the individual, and I think sometimes, because they're not centred around the individual, there are gaps in our service delivery, and that's one of the greatest difficulties that I think we have in managing and improving the care of people. And ultimately, I think what we gain, particularly working in the people in the emergency service and veterans, will have a very significant benefit to the broader community. Thank you very much.